So I'm going to say good afternoon. We are at the 2 o'clock hour. My name is Deborah Markinson. Natalie and I are going to be sharing some really wonderful research that's been done by the Health Communications Research Center at the University of Missouri Journalism School. So first, that's who we are. I'm based at Children's Mercy and Natalie's at the Health Communications Research Center. We wanted to do just a couple of announcements before we get started. One, we are recording this webinar and it will be posted on the MOCAN website. And at the conclusion of the webinar, we will send that link to you along with an evaluation so you can tell us how we did and how we could make this better. We will leave time for questions and answers at the end of the presentation. And if you have questions while we're going, please just use the chat box to ask those as we go along. We're going to save them till the end, but we'll get to as many as we possibly can during that time. So I'm going to spend just a few minutes giving you an overview. Natalie's going to give you the bulk of it in about 40 plus minutes, and then we'll close out with the questions and answers. So the first thing we wanted to say is that we really do have a story to tell. In Missouri, we're still concerned that the rates of obesity for children and adults is far too high. And that's the bad news. The good news is that we're taking comprehensive actions to address this complex problem. In 2014, the Missouri Children's Services Commission set up a subcommittee on childhood obesity, and they did a comprehensive review of the evidence, had 4 public hearings, as well as compiled a report that you can see the link to that report on the screen, and we will send these slides will be available so that you can access that directly. But after their comprehensive work, they came up with 5 recommendations, and there has been great work being done to implement those recommendations since 2015 when that report was published. And we have many partners working on this issue. We have received funding for several of the domains to implement recommendations within those. That includes the school, the child care, and the treatment. We're going to focus on the treatment domain and the healthcare providers today. And in the treatment domain, Children's Mercy, in collaboration with Washington University, submitted an application and received funding from the Healthcare Foundation of Greater Kansas City to do a pilot of regional training for medical providers in the assessment of their patients and the assessment to determine if their patients with obesity warranted referral for more intensive treatment. And so the training has started with that group. In addition, we are doing training for behavioral interventionists and dietitians who are delivering that more intensive treatment therapy. And that's all in anticipation of the expansion of Medicaid coverage for these services. So we have been fortunate enough to start the launch of that regional pilot training to set up the stage for a statewide approach. And we've also been lucky enough to get additional funding through MOCAN to help secure the services of Natalie and her team at the Health Communications Research Center to help us communicate and align our messaging on what we're doing and how best to engage healthcare providers as part of this effort. So today's webinar is a culmination of Natalie's good work and her team's good work in this area. And it's being held at the regularly scheduled time for our healthcare advisory group. But we felt the content was so good that we wanted to share it beyond that group. So we opened it up to the MOCAN membership. And we're pleased that we've got about 60 people that have registered to participate in the webinar this afternoon. So today we're going to focus on communication strategies for healthcare providers. And Natalie's team also did research on how to communicate our message with policymakers And that discussion and workshop will be held in affiliation with the MOCAN meeting in July. So stay tuned for that. So at this point, I want to introduce Natalie. She has a rich background in public policy, advocacy, and public health. And she supported both state and national campaigns related to policy change, particularly for underserved populations in multiple states. And she has experience field testing campaign messages, as well as working with initiatives to increase healthcare access through telehealth. So she's obviously got some great experiences and a great education to prepare her to glean the insights from the research and package them and share them for us today. So with no further ado, I'm turning it over to you, Natalie.
Great. Thanks so much, Deborah. And you can hear me, right?
I can hear you.
Okay, just making sure. So we really appreciate the opportunity that we've had to work with Deborah and her team. And thanks everybody for joining us. I want to make sure that I thank my colleague, Andrea Carruthers, who worked with me on this, and especially a wonderful doctoral student, Julia Mulligan, who we get to work with on special projects. And she really worked some inhumane hours on this. So we really appreciate her help. So when Deborah approached us about this project, I want to just talk a little bit about those communication goals. We wanted to find the best ways to communicate with providers and also work to increase empathy for children who are overweight and reduce weight bias, and also to increase empathy for the parents of children who are overweight. Another goal was to help with recruiting for the training that Deborah mentioned. Now, we mainly focused our audiences on the providers who would be doing the referring to the programs. So in other words, to pediatricians, nurse practitioners, et cetera, who would see those children and then refer them on to the behavioral services and the nutritional assistance therapy. We also wanted to make sure, especially with the providers, that we were increasing support for prevention and for treatment. So of course, in the public health realm, we really focus on prevention as that gold standard, but there is a growing body of evidence that supports effective treatment for children who are overweight. So we wanted to make sure that people were aware of that. And lastly, we wanted to improve upon research that the Missouri Foundation for Health had done. Let me say, they had done excellent research, and particularly around their community health survey that was statewide that they did in 2014. So we wanted to look at the recommendations they had made and then see if there had been research since then that also supported that, or if there was anything that had changed since they had done that research. So we started with an extensive literature review, and this was again an update of the Missouri Foundation for Health communication recommendations. So we really focused on research that had come out since 2014, although if there was a seminal work or if there was other work that we found that maybe Missouri Foundation for Health didn't have as part of their literature review, we tried to make that part of our review as well. Let's see, following the literature review, we interviewed 3 healthcare providers, and these questions were informed by the lit review. And of course, we wish that we could do 50 interviews with healthcare providers, but we were limited with budget and time. These were a self-selecting group of providers that were recommended for us to speak with, and we really got some rich information from them. So the 3 providers we talked to were all women, and the first one was a pediatrician at a children's weight clinic in a university setting, an undisclosed university setting. The second provider is a very hardworking provider who sees mostly pediatric patients in a rural, low-income setting. And the third provider is an RN who works on the side of children who are referred to a clinic, and so she leads a care coordination team. So they had a wealth of experience that was really helpful for us. Following the data collection, we prepared a report, made recommendations, crafted messages, and created several of the tools that we're going to discuss here today. I just want to mention that I am not a healthcare provider, so in our recommendations, we recommend that providers talk to other providers, but I just wanted to mention that as a caveat. I'm sort of breaking one of our rules here. So first we wanted to look at weight bias and some of the issues surrounding weight bias, which is a really sensitive issue, but it has an impact on patient-provider communication. It causes us to evaluate people who are overweight differently, or the parents of children who are overweight differently. It doesn't mean that someone is a bad person. These images and stereotypes are pervasive, and we all embody them to a certain extent. But we need to take an honest look at these. By the way, this is an image on this slide that we want to discourage using some of these negative images that go along with weight. You know, you often see somebody with a bare midsection. That's kind of an objectified photo when we're watching the news or things like that. So this is a picture don't, not a picture do. So we wanted to look a little bit at some of the problem frames that surround the weight bias issue. And there's the medical frame that we're very familiar with, and that's the idea that medical professionals are best suited to treat overweight. Then, of course, the public health crisis frame that we're very familiar with, and that's the idea that we need to reduce BMI at the population level. And we tend to look at health and add in those economic issues that we often call social determinants of health. And then there's the immorality frame, which you probably know of, but maybe don't know it by name. And that's the idea that being overweight is the evidence of sloth or laziness, being a bad, lazy parent, and some of these really negative ideas. And the fix for that under that frame is that the person or the parent just needs to have better self-control or restraint. And this is kind of a proponent that we hear in political circles somewhat. And also the food industry tends to kind of propel this idea. And that's because if the individual is responsible for the problem of being overweight, then that means that we don't need to look at practices like advertising within the food industry or what's in the food that children are getting at schools and things like that. So different problem frames lead to different blame frames. And the immorality frame is the one that's most associated with the main blame frame, which is personal responsibility. The personal responsibility frame is challenging for us in public health because people who believe that being overweight is only the responsibility of the individual do not see policy solutions to that. That's more, well, people just need to start eating right and be stronger. The immorality frame is most closely tied to the personal responsibility frame, but we do need to be aware that public health campaigns can inadvertently promote the personal responsibility frame. And kind of my theory on this is that because some of the funding that we have for public health makes it more challenging for us to promote policy solutions sometimes because, we can't lobby and things like that, that sometimes we end up focusing more on behavioral changes that individuals can do. So even if we're doing a really positive campaign encouraging people to eat more fruits and vegetables, that's still the idea that it is on the individual to make that change. All right. So we know that for those of us in public health and who are healthcare providers, it may be especially difficult to look at weight bias or other biases within ourselves because we are accustomed to a commitment to science and objectivity. So we may be especially sensitive to looking at that in ourselves. But the reason it's so important is because it can really affect communication between providers and patients. So if a patient perceives, whether it's real or not, that he or she is being judged by the provider, that affects the patient. It actually makes the patient less likely to come back for other visits. It makes it more likely for them to skip visits. They may be less likely to comply with the provider's advice. And this link really shows that weight bias creates several multi-level barriers to effective childhood obesity management. And of course, in return, providers, if they feel like their patient isn't listening to them, may feel very frustrated, and then that can go back into the next visit and kind of have a cycle of negative interactions. So our research also showed that weight bias is less prevalent in certain groups of people who tend to have more empathy. And so providers who are women or in underrepresented minority groups actually tend to have less weight bias and display more empathy. And interestingly, these two groups are also more likely to accept Medicaid. So because of that, we think it's a good idea to look at some of these groups as a good starting place for some of the recruitment that's being done. And also our research showed that doctors really do, there's this filter down, trickle down thing that when they hear about a program or referral program or something like that working well for other providers, that's when they start to pay attention. So, yes, so our messages, especially after we talked to the providers, we found that there was a lot of resistance to the idea of weight bias within providers. So the providers we spoke to didn't even think that it affected any of their colleagues or other professionals' interactions with patients. So there's extreme sensitivity to this. And because of that, we never really directly addressed weight bias in our communications, but we designed our messages to help build empathy and improve provider-patient interactions. So getting to those messaging recommendations that we came up with, and the first three that we're going to talk about are related to recommendations that the Missouri Foundation for Health had already made, and so those are the ones we looked at to see if our research showed that those still held up, and they did. The first one is that people really need to help connect the dots between childhood obesity and policies and activities that are designed to reduce childhood obesity. So the Missouri Foundation for Health Communities survey found that when respondents, most of them, 90%, had heard of at least one activity or policy designed to reduce childhood obesity in the past year. So maybe they had heard of farmers markets, or they had heard of community gardens, or they had heard of Eat Smart in Parks. However, when they were asked if they had heard about any efforts to reduce childhood obesity, 90% said that they had not. So what they deducted from that is that people were not connecting these activities with childhood obesity. This is also an issue that we need to connect these dots, because when people only see personal responsibility as an issue, that may also be an indication that they don't understand that there are other contributing factors. And if we show them that these solutions are linked, then they may also see that the causes are linked as well. So the next recommendation that the Missouri Foundation for Health had talked about, and this is consistent with Robert Wood Johnson Foundation as well, research, that people, it is so deeply ingrained, the idea of personal responsibility, that if we just start off with talking about social determinants of health without first acknowledging personal responsibility, people often just discard that information. So the recommendation is that it's best to start first with this and then talk about some of the other causes. Now, We did find a little bit of research that slightly refuted this, but it was a small amount compared to the supporting evidence. But we should look and see in the future if there are any changes to this idea. So telling a story is another recommendation that we think is really important. In public health, we tend to get really excited about numbers, and we want to talk about statistics, and those are very important. But we know that even people who are very objective and science-oriented still want to hear the heart of why they're doing something. So stories plus statistics are more effective than either of those two alone. So we also wanted to ask you, people on the call, if any of you have any stories that you want to share about children you know in your life who are overweight and any of the issues that they've had to overcome. And of course, even if you don't want to share those stories with us, we know that if you are talking to people, your own provider, for example, or other providers in meetings, that if you can tell a story from your own life, that is really helpful. All right, so we've already mentioned images, but I want to talk about this again. So when we watch on the news, we often see if they're talking about overweight, they show pictures of people where their heads aren't showing, their midriffs are showing, they're eating fast food, they're sitting and watching TV, and this really reinforces those negative stereotypes. So we want to encourage, and images are very powerful, people to use images of people who are overweight, doing walking or being active, eating healthy or shopping healthy. But even more than that, we want to show that their lives are not just related to what they eat or exercise, that they're also productive, normal citizens that go to meetings, study, go to class. So showing people doing other activities that are productive. Okay. I think we have something that has gotten unmuted somehow. Okay. My apologies. Okay. I'm looking and it looks like everybody's muted, so I don't know what was happening.
Somebody has special powers.
Okay, all right. I'll get started again. Sorry about that. All right, so as we mentioned, wherever possible, it's important to have peer-to-peer communication. And this is, we found that a lot of providers are really feeling criticized, and there are several reasons for that we'll get to. But, even better than maybe a nurse practitioner talking to dietitians and doctors, if we have nurse practitioners talking to other nurse practitioners, that's even more effective because people are more likely to listen to us if they've had the same experiences that we have had. And so we want to encourage communications to stay positive. And this is because there are a number of stresses that providers are experiencing. One is from payers, and we've all heard that it is very time consuming to meet some of the regulations and do some of the paperwork. Primary care providers may feel that the payers are making all the calls. Another stressor that I hadn't considered as much is from from specialists. So primary care providers sometimes feel that they're supposed to refer everything out, and that can make them feel like they're not qualified to treat things. So I mentioned that because we are encouraging them to refer patients out to weight clinics. And so if we experience resistance, that might be something that we would want to look at. Thirdly, providers can feel stress when the patients don't seem to follow their orders. So we want to do what we can to try to alleviate some of that stress. One of those things is trying to help providers be able to communicate better with patients to alleviate some of that stress. So communications should be crafted to reinforce the importance of the providers and the community and position them as the ultimate experts. We want to frame interventions and messages to physicians as improving, not controlling their decision-making or autonomy. We want to show that it's time-saving for them to do this, that it's cost-effective, and it can improve the quality of their interactions with patients. And we should also mention that there are, of course, positive changes happening within the healthcare system. So the move to value-based care, we think, will actually be very helpful in obesity management. The current move away from fee-for-service and toward value-based and patient-centered care models suggests possibilities for improved patient-provider relationships. The expansion of the patient-centered care and affordable care organizations creates an additional opportunity for treatment of childhood obesity. The structure promotes team-based coordinated team care consistent with family-based behavioral treatment. So helping to improve the health of children within the ACO can reap cost savings in years to come. All right, so quickly want to say that it's important that we find ways to personalize statistics. And one of the easiest examples of this would be that if we were talking maybe to a policymaker or an elected official, we, instead of giving national statistics, we would probably want to localize that to county statistics if we had them. And I'm going to give a more relevant example when we talk about the talking points that we'll be getting to. Next, it's important to be consistent. So one of the studies we looked at, it showed that once a campaign to promote a referral program had started to taper off, you saw the numbers of referrals really go down because providers tended to forget about it. And so it's something that we really have to, in our campaigns and in our communications, make sure that we're continuing to talk about those programs or those issues. All right, we want to encourage effective provider communication. So one of the things that we learned is that it is very difficult for providers to talk to parents and patients about weight. We really didn't understand the depth of this even after the literature review until we talked to the providers. Each of them brought this up as an issue. So we know that most people, about 95%, according to Missouri Foundation for Health statistics, believe that the primary responsibility for overweight is with an individual or with a parent. So when providers talk to parents about the weight of their children and say that their child is overweight, that is read by the parent as saying that they're a bad parent. So you can understand when you look at it that way why it's such a sensitive topic. So we want to look for ways to help with dealing with this. Doctors also mentioned, or providers we talked to, some real misperceptions by parents. So parents may believe that when a child is young, a toddler, it can be very cute when they're a bit, chubby, and that the child will outgrow that and not see that as having any long-term health consequences. And we also, of course, they mentioned some of the real issues, the social determinants of health that make it difficult for parents to deal with these issues, such as transporting children to classes, having time to cook for children. So we want to really encourage providers to talk about healthy weight instead of starting with the child being overweight, to talk about what a healthy weight would look like. We also want to encourage them to use a developmental approach when they're talking about weight. So one of the providers we talked to, who was in a really difficult, challenging practice, I should say, and so she really focused more on BMI charts and showing parents how far off the chart their child was. Another provider we talked to used a more developmental approach. And so the way that she talked to the patient or the parent really depended on the age of the child. She said that even as young as age 4 or 5, if she brought weight up, she would often see the child hang his or her head and really feel hurt by that. So she would really start with talking about that the child is perfect just the way they are, but they want to talk about what will help them to stay healthy and happy in the years going forward. Another provider talked about that her team uses motivational interviewing, or a hybrid of motivational interviewing. So I know a lot of you are familiar with this, but this is the idea that it's important to set goals with patients or parents that are more related to functioning than about how much weight they want to lose. So for example, if a child might want to be able to keep up with the other Girl Scouts on the hiking trip coming up. So that would be then what would be used to talk about, well, what needs to be done in order for that to happen. And a really cool side effect of motivational interviewing is that it increases empathy by providers. So when providers are talking more deeply with patients, when they have time to do that, they get to know more about what are those barriers that really make it difficult for them to follow the advice of the doctor. All right, so we need to know how to reach providers if we're going to talk to them. So one of the ways that was suggested is that we really need to get to be friends with the gatekeepers, the office managers, so that they will help us be able to get through email or phone calls to providers. Also, that is very useful to have people in the office or other providers to forward emails so that providers are more likely to pay attention to them. And lastly, that organizations, these were specific organizations that were mentioned that providers are more likely to open an email from. And these were Missouri HealthNet, Missouri Primary Care Association, and the American Academy of Pediatrics. All right, so what providers want from us. And I didn't put this in the toolkit because this question was really more about specifically what they would like to see in the training, but there were some things that we can derive from this that I think are really useful in thinking about communications. So first, there are general obesity statistics that they would like to see, information about how to diagnose obesity. And these are some of the things that in public health, particularly the basic statistics that we can provide. They also want to know what resources are available to help patients in the community. So they may be aware of social determinants of health, they may want to help their patients, but feel powerless to be able to do this. So there are regional flavors of resources available, and that's something that we as MOCAN members can really help providers, keep them informed. I can probably name 5 or 10 resources in Columbia that you wouldn't be able to find on the internet, even if you were looking for them. So that's local knowledge that we can help with. Guidelines on using medication. And the reason I mentioned this, and this goes back to that problem frame. So the medical problem frame draws the solution can be surgery or medication. Not saying that those things are bad, but we need to know that when we're talking to providers, we may be talking about a lifestyle behavioral change intervention, but they may be thinking when they hear the word treatment, medication or procedures. So it's important for us to recognize that. They want practical advice about diet planning, harm reduction ideas, like we know that people are going to have to eat at fast food, so what's the best way to eat there that will cause the least problems? How can people eat on SNAP nutrition programs also? And then communication tools that we mentioned, like motivational interviewing. I actually thought motivational interviewing trainings would be prolific, and it turns out that they're not necessarily. One of the providers we talked to said she had never heard of a motivational interviewing training related to childhood obesity. So getting into some of the tools that we created, the first one is the talking points. So these were informed by our research. They are designed to be used in verbal communication with providers or to be taken to be used in written communication. However, they are not designed to print out and just give to a provider as a package. Not that there's anything offensive in there or anything, but we have other tools that we designed to actually be given to providers. So we're just going to go through a few of these talking points. And we did write this language in a way that we think will be most effective. I'll try not to read everything to you, but hopefully you'll get a chance to read through these. The first one is really about these, the trainings and the effective treatments that we are encouraging providers to use, the medical nutrition therapy and the family-based behavioral therapy. So we want to make it clear that we hope that these are going to be reimbursed by Missouri Health Net soon. These are evidence-based practices that we didn't just pull out of the air. They really work. And also about the 2-hour training that is available, and we want to ask your help as MOCAN members and affiliates to help promote this training and raise awareness of the training. All right, so we want them to know that their patients and families are listening. And this is really the idea of positioning providers as the authority and someone who's well respected by their patients, even if sometimes they don't feel that way. So there's a lot of fear of stigmatizing children, and we want to encourage providers to use a healthy weight frame and a developmentally appropriate approach to help improve their communications and reduce the negative impact on body image. We also want them to be able to understand that it is difficult and that parents are under a lot of pressure, and to show empathy for the parents. And then, of course, we are encouraging providers to go beyond the BMI charts, that their data may be less effective in motivating families than if they helped them to set their own goals and focus on their reasons for wanting to change. So talking point number 3, and this is really about referring patients to treatment for childhood obesity and what are the benefits to their practice and the patients and parents. So first, we want to point out that it's a value-based initiative, and it can save nearly $20,000 in direct medical costs through adulthood. So doctors who are working with accountable care organizations that save in cost savings prevention, this can be especially motivational for them, not that they don't have other motivations. And the phrase value-based is sort of conjures for providers the idea of what they really went into medicine for, which was really to help people. So getting away from some of this fee-for-service stuff. You see your patients for only a few days out of the year, but what about all the days in between? So we want providers to know that they shouldn't be expected, and it doesn't really make sense that when they just see their patients for a few minutes every year, they can't do it alone, help improve the situation of their patients without additional assistance from other providers. So in the case of these referral programs, we're looking at behavioral health providers, dietitians. As many as 1 in 5 of your pediatric patients could benefit from new evidence-based treatment options now available for childhood obesity. The reason we're saying this is because in one of the studies we reviewed, it was a prediabetes intervention, and we know that there are 1 out of 3 people in adults in the United States that have prediabetes. But when a provider was told that it could benefit 1 out of 3 of her patients, that was more motivational than just knowing that 1 out of 3 adults have prediabetes. So saying that 1 out of 5 of your pediatric patients could benefit is really just based on that obesity, childhood obesity statistic, but it's very effective. One other I wanted to mention, you can help prevent comorbidities like type 2 diabetes if you act now. So this is one thing I would have never thought to mention to providers because of course they know this. However, we can't forget that these things are not always top of mind. So providers are very busy, and in fact, in a study we reviewed, this did make them more likely to refer patients to a program. Family-based treatment can help ensure that children are living in healthy environments by changing parent and child behavior. So this can really help families as well, the adults in the program, as well as the children. Not only is this motivational for providers, but this can also be motivational for payers. So payers have not been as interested so far in childhood obesity as in adult obesity because they don't know for sure if the child is still going to have the same, be brand loyal to that company when they're adults. So if we can show them that this is going to have more immediate cost benefits if they cover this service, then that may help improve coverage. So many low-income families face real obstacles, and we want them to know, we want providers to know that they see the effects firsthand and are really the best advocates for these families. We know that for some of us on the call who work for the state, our hands are sometimes tied when going and talking to policymakers, but providers usually are able to communicate and are very well respected by policymakers. So we really want to find ways to encourage providers to do this. And sometimes that requires, I shouldn't say hand-holding, but a little bit of a nudge because that's not where they see their role usually. And also, providers can help families by giving them practical, situationally tailored advice for improving weight management. Referring patients to community-based resources can also help them to succeed. So again, that's something that we as MOCAN affiliates can help with the local knowledge about what resources are available beyond medical resources to help patients. All right, so in the toolkit, we have a sample newsletter. I just wanted to make sure that you are aware of this. You can feel free to copy it, or even better, tailor it to the audience and for whatever publication that you might be using it for. Social media, we've created some sample social media posts. Now, these are just examples, and it's easy for you to make your own social media posts from other talking points that we may not have mentioned. You can make your social media go further by plugging into trending hashtags. We find that health month observances or even health week observances like, National Heart Month can have some really impactful hashtags. You can also look at creating your own hashtags. We also encourage you to strategically tag other organizations who you want to know about the work that MOCAN is doing or the referral program, for example. And there are lots of ways that you can use this, and we're always happy to give advice on this. It's best to use photos with those posts if possible. So remember the University of Connecticut and their image database that we mentioned. And I want to make sure that you know how to find MOCAN on Facebook and Twitter. So that's on this slide. We will be doing some posts that you can look for, some Facebook posts and tweets that you can share or retweet. And we encourage you to do that. And then we have a brochure that, let me just go ahead and show that to you. So this brochure has a lot of the messages that we talked about in our talking points. It also publicizes the training and lets providers know about treatment options. So I want to warn you that the one that is attached to this toolkit is designed for professional print jobs. So it's designed to be printed from an offset printer. These trifold brochures are a little bit tricky when you fold them. They don't always match up. So if you just print this from your office printer, the folds are not going to match up properly. However, we plan to have that as one of the resources on the MOCAN website so that you could, if you're going to have some printed in bulk professionally, you can do that. Or you can look at the office printer version and just print off a few yourself if you're planning to, for example, share it with your own primary care provider. Oh, and that also is the same if you're going to have a few printed off at Kinko's. They don't do offset printing. They would have to only do that if you did a large quantity there. They would send it out to an offset printer. So in conclusion, we want to make sure that people are using messages that are clear, persistent, and peer-to-peer when possible. We want to position the provider as a respected figure in the community and emphasize the role the program could play in helping to improve the communication and compliance of patients. Providers will be more likely to participate after they have heard of peers having positive experiences with the program. All right, and some of the next steps we have already mentioned, but we will be sending an evaluation following this so we can find out if this was useful to you or what else might be useful to you in the work that you're doing. And we'd also love to hear more about what your plans are to use these tools for. That's something that we are going to be tracking, and in 3 months I will send out an evaluation that will have an online survey link. We would love to know which tools you've used, with whom, and what the outcomes were. Any information will be helpful for us to provide to MOCAN to show the effectiveness of the work that we've been doing. And as an example of this, Deb Markinson has already used the sample newsletter in a publication she sent to PEDline for the Missouri Academy of Pediatrics. And this work has also been used to inform the training that's being provided and the recruitment materials for that training. Remember to look for MOCAN posts to share. And the policymaker portion of this, which Deborah shared at the beginning, we will be doing an in-person live session at the MOCAN July meeting. So we look forward to seeing you there. And we will also make sure that portion of the toolkit is available to you, even if you're not able to attend. All right, so we want to thank our funders, of course. And I also have references here for you to take a look at. Now, our literature review had way more references that have been distilled. So if you have other questions, please contact me personally and I'll be glad to provide you with the information that helped us to inform those talking points. All right, so I think we've reached the question and answer portion. And Deborah, I don't see any questions yet.
So this is your opportunity. If anybody has any questions or any communication issues that they've been dealing with that they'd like to just kind of pick Natalie's brain on how that she might guide, or some other thoughts and considerations for how to travel that territory, she's here for us. And so we'll give it just a minute or two. If you have any questions, just type those in. If you don't have any questions, then we want to reinforce that the slide set will be available on the MOCAN website, as well as the toolkit, as well as other pieces. So one question I'm getting, Natalie, is can you review what is meant by tips for talking to parents and children? Should come from providers, peers when possible?
Okay, so what I especially want to say there is that if it's coming from me and I'm not a provider, that providers may feel that I am talking down to them and saying that they're not doing a good job at their job that they know better than I do. So we want to look for provider champions, and we already have some provider champions who are talking to other providers and sharing communication tips. The training that Dr. Hampel and Deborah Markinson are doing also embodies some of those communication tools and is helping to promote those. So, and we, as I said, if doctors, if we want to spread the message to doctors, if it's coming from a doctor, that is the best case scenario.
Are there any other questions or comments? And here's a long one that has come in. Before that, how can we be careful to not reinforce the personal responsibility frame when the treatment options that are available are aimed at families and individuals? Mm-hmm. So it's kind of a conundrum. You want to take a stab at that, Natalie?
Sure. It is a conundrum. And, part of the background of this is that we were looking at talking to policymakers and kind of the public too, besides talking to providers. The provider part, we focus a little bit more on the treatment part. And so, yeah, it is a constant struggle. It's something that we need to be aware of and see where we can find ways to minimize that. But it's absolutely true that it is an individual-based approach for treatment.
Another question or comment is just thanking you, Natalie, for the helpful information and recognizing how hard and difficult it is for us to approach providers. And they're suggesting or asking, is it possible to have a standard questionnaire that would have open-ended questions for patients that might want more information? So that's an interesting question. And perhaps someone who might be able to guide us on that would be Dr. Sarah Hampel. She's a pediatrician at Children's Mercy who's really an expert in that area. And Karen Stevens, the dietitian that works in the weight management clinic. They might have some insights for how best to manage that, or if there are some tools out there that could be provided for patients and their families.
Hi, hi, this is Sarah. Can you hear me okay?
Hi, Sarah.
Hi. So there are a few options. We typically in our weight management clinics tend to try to leave some open time really toward the beginning of our visit after we've explained the clinic to just try to do what we call agenda setting with a family to really see what are the pressing issues on their minds. And sometimes you can phrase that question in a way such as, what are you looking to get out of today's visit, or how can we best serve you today? What are the questions that you would really like to find answers to during your visits with us? Those would be some examples. We also just have one sheet that we have in the room that families are given as they enter the room, that it's explained to them if they have certain questions about eating or physical activity or family-based changes, that they can jot those down, and then we can talk with them during the visit and make sure that we're addressing those questions before the family leaves. And then the only other resource I would say that is not yet available, but we hope will be available in the next couple months, is through the American Academy of Pediatrics Institute for Healthy Childhood Weight. We were part of several children's hospitals that helped develop a survey for what families are looking for in treatment. And it says at the top, what are you looking for in the blank clinic or program? So a clinic could use that and customize it with their own clinic name. And it asks questions about what they're looking for related to eating and physical activity and behavior change, family support, and what would they see as success.
Thank you, Sarah. That was helpful. Well, at this point, in view of the fact that we don't have any other questions that are popping up in the chat room, do you have one, Natalie?
Well, I see Laura McCullough was asking about, or did we already answer this? Yes.
Do we have model community resource sharing? So I think Sarah touched on that a bit.
I would say that I think that's a little different, and I think it's a great question. There are a few models that I am aware of. One of the best, I think, is from a group in Chicago affiliated with the Lurie Children's Hospital there. They partner with a number of pediatric practices, and they have created basically some resource packets that are customizable to the practice. Such that they could keep lists of different community organizations that offer physical activity and so forth. They actually have it online, kind of like a Google map type of thing, where they can put in their address or their zip code and up appears on the screen different healthy eating, active living resources for the particular address. I don't know if, and that hospital is Lurie Children's, it's Lurie Children's. They've published about this, and I would be happy to send the article after maybe Deb, I'll send it to you or Natalie, and we could or Dana, and we could get it distributed. There is also a little template for community resource sharing that we have on the healthcare web page of the MOCAN website. It's just a little example of what you could use in your office.
Okay, thank you, Sarah. That was a good question, Laura. Thank you for that. Well, because we are approaching the end of our hour, I want to thank everyone who participated. Please note that we will put the toolkit as well as these slides on the MOCAN website and should have that up within a day or two. You'll also get an email with an evaluation just on the basic mechanics of the webinar. Did this deliver the information in a manner that was useful to you? And as Natalie said, in about 3 months, she'll send you another link to quantify how you might have used any of this information. I've found it to be very useful just when I need to send a blurb to someone, just to pull from the talking points that Natalie and her team have put together. So we'd love for you to keep track of those and just share back so that, and if you find other ways that we haven't thought about, we'd love to be able to share that with the group. Want to once again acknowledge the funding that we received from the Healthcare Foundation, the work that has been done by the Missouri Foundation for Health that was part of the foundation for this research, as well as MOCAN for providing supplemental funding to help us really tease out our messaging points. We also want to thank Natalie and her team. Clearly, they gave above and beyond the resources made available to them, and we appreciate their extra efforts to pull this vast amount of information together in very useful manners. And also want to thank the MOCAN members who were very useful in reviewing components of this along the way and giving us feedback on how best to pull together this toolkit and these resources. So look for an email that will summarize some of these key pieces. And if you're interested in the webinar to come, we'll keep you posted on that as well. Thank you all.
Thanks, everybody.